Thank you so much for that introduction, and thank you for inviting me as well. I'll apologize in advance if I'm coughing. I have a bit of a cold, so I think it should be okay, but there might be some coughs. So my name is Kinza Degerlund Maldi, and I'm here today to present our paper, Cost Utility Analysis of Esketamine and Electroconvulsive Therapy in Adults with Treatment-Resistant Depression. So why did we decide to do this research? Well, treatment-resistant depression can be difficult to treat, and electroconvulsive therapy, or ECT, has long been used for treating these individuals, and it's also considered highly effective. However, a few years ago, intranasal esketamine was also approved for treating TRD. So we now have these two treatment options, which are both viable for these patients. We have research that indicates that ECT can be more effective than esketamine, but it can also cost more. However, is it worth paying more for ECT? So the aim of our study was therefore to evaluate whether ECT or esketamine is the more cost-effective option for treating treatment-resistant depression. So how do we know what is cost-effective? Well, what we do is we look at the costs of ECT and the costs of esketamine, and then we compare it with the benefits. So there's two ways to look at this. First of all, if one of the options is costing less and at the same time generating greater benefits than the alternative, it's going to be cost-effective. However, if an option generates more benefits but also cost more, it can still be cost-effective. And to find that out, we look at the ICER, or the incremental cost-effectiveness ratio. And this is calculated by looking at the difference in cost between ECT and esketamine divided by the difference in benefits. And benefits is measured in quality adjusted life years, or QALYs. And this is the number that goes between 0 and 1, where 0 is death and 1 year is, and 1 is 1 year in perfect health. So for an example, if you live 6 months in perfect health, then your QALY would be 0.5, because it's half a year in perfect health. When we do these calculations, we then receive a number, which is the ICER, and this number is compared to a threshold, which will determine if the intervention is cost-effective. Different countries have different thresholds. So in the UK, NICE recommends a threshold in the range of 20 to 30,000 pounds. So that means if the ICER is below 30,000 pounds, it is generally considered to be cost-effective. So I'm going to show you an illustration of the model in the next slide. First, I just want to explain the different treatment options in the model. So we had intranasal esketamine, ECT, and standard treatment. So intranasal esketamine was based on the treatment protocol by Janssen. So it was prescribed by a psychiatrist at the community mental health center. And the patient had 2 appointments per month for this. So they had one in the beginning to be prescribed and then one at the end for follow-up. They received the medication at the community mental health center by a nurse, and they had 2 doses per week when they were depressed. And then if they reached remission, they had 1 dose per week for the first 4 weeks, followed by 1 dose every other week for a maximum of 6 months. And then they moved over to standard treatment. ECT, it was quite similar. It was also prescribed by a psychiatrist at the community mental health center. They had 2 appointments per month for this. And when they were depressed, they had 2 ECT sessions per week. And in remission, they had standard treatment, which was medication. However, we did make a second model, which we called the maintenance model. And in this model, the patients received maintenance ECT when they reached remission. So they had ECT weekly for 6 weeks, then followed by twice a month. And then we had standard treatment, which was medication. And the patients received this in all the states, so both when they were depressed and in remission. Excuse me. So this is a illustration of the model. So the model is supposed to mimic the real world. So you have the blue states. So the blue states are depression, and then you have the green ones, which are remission. And the arrows between the states indicate how the patient can move between being depressed and being in remission, and between receiving different types of treatments. So I want to focus on these two states. So here you have depression, and all the patients started in this state. They were depressed, suffering from TRD, and they could either receive esketamine or ECT. And then after 1 month, they moved to one of the other states, depending on the effect of the treatment. So if they were in remission, they moved to this state and received the treatment that I showed you in the previous slide. So they received esketamine at a lower dose, or they received standard treatment if they had ECT, or in the maintenance model, they received maintenance ECT. If the patient didn't reach remission after the first month, so they were still depressed, they moved to this state and received standard treatment. So we made the assumption that if an individual didn't remit after the first month of receiving ECT or esketamine, they would move over to receiving standard treatment, and they received standard treatment throughout the rest of the model. So the model works by comparing treating treatment-resistant depression with either esketamine or with ECT. And we then predict the patient prognosis based on them receiving ECT or esketamine during their lifetime. So the model started when the patients were 45 years of age, and it ran until they were 80 years. So to be able to predict this, we need 3 types of data. We need the treatment effects, we need the costs, and we need the qualis. And these were derived from different studies and different sources. We had no study that compared ECT to esketamine, so we derived this from different studies and we made an indirect comparison. When we looked at these studies, we tried to find sort of similar populations. So we wanted similar age group, similar level of treatment resistance, similar inclusion-exclusion criteria, and similar healthcare systems. So, for example, with the ECT studies, we didn't want patients with mania, catatonia, or schizophrenia. So I'm going to explain now the different types of data that we used for the model. So for the effectiveness of esketamine, we had 2 studies that were randomized double-blind active control studies that evaluated intranasal esketamine plus a new antidepressant. So for the remission study, it was 342 patients, and then the ones who reached remission, they were followed up in another study where we had 297 patients to capture relapse. The effectiveness of ECT, we had 1 study that looked both on remission and relapse. It was also an RCT with 22 patients in London. As you can see, it was quite a small study. However, we compared the results in this study to other large studies, and it was similar results. We also looked at changing the effectiveness in the sensitivity analysis, which I will explain later. And then we had 1 study to look at relapse while receiving maintenance ECT. So we used that for the second model that we made, the maintenance model. With the standard treatment, we had one study, the American TRD trial, where we captured both remission and relapse. And mortality during depression was derived from 2 studies. So the first one was a study that looked at all-cause mortality during depression. And then we had the Swedish study that looked at the increased risk of death when you have treatment-resistant depression compared to depression. And lastly, mortality risk in remission was derived from a life table. So cost and benefits, we applied a societal perspective in our study. And that means that we aim at capturing the costs regardless of which budget they fall under. So we include both direct costs and indirect costs. The direct costs, also called the healthcare perspective, and these costs are related to the utilization of medical resources. And then we have indirect costs, and they are related to loss of productivity and informal care. So we derive these costs from different sources. We had the NHS reference cost, where we had some of the costs for healthcare visits. Then we had the cost of ECT from NICE, and Janssen had the cost for esketamine. And we had a study by Macron et al. Who estimated the economic cost of treatment-resistant depression in patients living in London. And this study looked at all the costs related to TRD, so not just the cost related to the condition itself, but patients accessing A&E more, patients seeing their doctor more because of health problems, and those kind of things. And the benefits, as I mentioned previously, were captured in QUALIS, and we had a longitudinal study for this. So if I go to our main findings, here we have the societal perspective. And first we have the costs for ECT and the QUALIS for ECT. And then we have the cost and the QUALIS for esketamine, and here is the difference. So what we can see from a societal perspective is that ECT is cheaper, costs less, and it gives more QUALIS. So ECT dominates esketamine. If we look at from a healthcare perspective, we see that ECT costs more, but it generates more QUALIS as well. So when we look at the ICER, we get an ICER of £7,000, which is below the threshold of 20 to 30,000 pounds. This is the maintenance model that we made. So in this model, the patients that reached remission from ECT continued to have ECT. And here we can see that from a societal perspective, ECT costs more, it generates more QUALIS. So we have an ICER of 27,000, and this ICER is within that range that NICE suggests. And if we look from a healthcare perspective, we see that the ICER is 39,000, so it's above the threshold. If we go back to this first main model again, to the results here, what we can see also is that ECT is cheaper from a societal perspective because we have more patients returning to work, and esketamine is cheaper from a healthcare perspective, just looking at the costs. We then also conducted sensitivity analysis, and the reason for doing so is when we make this model, we base it on assumptions. So when we do a sensitivity analysis, we can look at what impact these assumptions have on the results and on the cost effectiveness. So we had 9 different conditions for the sensitivity analysis. So we looked at changing the productivity loss, the frequency of ECT. We decreased the remission rate for ECT, and we increased the remission rate for esketamine. We looked at changing the length of the model. So I mentioned it ran for a lifetime. So when we looked at the length of the model, we changed it to 5 years. And then we looked at changing the QALYs. So we conducted 20 different sensitivity analysis in total. And we could see in the main model that ECT was cost effective compared to esketamine in all the scenarios. And in 12 scenarios, ECT dominated esketamine. In the maintenance model, ECT was cost effective from a societal perspective in all scenarios but 2. And from a healthcare perspective, the ICERs were above the threshold in all scenarios. So what we concluded was that from a cost effectiveness point of view, ECT should be the first-hand option for individuals with TRD when other first-line treatments have failed. We saw that these findings were robust in the sensitivity analysis, and there was no scenario where esketamine was cost-effective. We do think that further research regarding potential subgroups of individuals where esketamine could be cost-effective is warranted, and further research using longitudinal or naturalistic studies is also warranted. Thank you.
Thank you very much indeed. That's a really nice, succinct sort of presentation there. Gives us lots of time for questions. I think there will be quite a few, so let's get stuck in. Please put your questions in through the Q&A. I'm just going to read them out as we come, actually. So first question is I guess a very pertinent one. Is the result due to high cost of esketamine, and would it be different with racemic ketamine?
I can't really answer to the racemic ketamine because I don't know much about how the effects of that and the cost of that. But what we could see in the study was that we had more QALYs from ECT than we did from esketamine.
Could we go back to your slide, the first slide of your results? Mm-hmm. Could you possibly put that back up, because I think that just gives us something to look at there.
Let me share.
Yeah, that's shared. Yeah, that's showing nicely. So, showing us your last slide. If you could go back a few, that's right.
This one.
Yeah. So if we, so the cost obviously is really important, isn't it? And how that's measured. And so can you just, I mean, an important thing here is how can you remember how you established the cost of the esketamine? What figure did you use for that? And did you do sensitivity analyses based on, well, presumably you didn't do sensitivity analysis based on different costs of esketamine and ECT?
We had, so the cost for esketamine was, first of all, the cost for the medication, and then based on the dosage.
Yeah. Then, so where did you get that figure from?
The cost of esketamine, we got it from Janssen.
So this was the list cost, was it? As opposed to the cost that might have been negotiated by governments that might be lower?
Yes.
Okay, fine. So that's the standard sort of opening cost, if I can put it like that. Yeah. Okay. Yeah, and then okay, because what surprised me about this was just firstly how much of there's a big difference in the societal and the healthcare cost for both ECT and esketamine. So, you know, I as a doctor, I'm sort of sitting here thinking about the cost of the drugs, but it looks as if from the societal cost, there are very big costs associated with the group that are both treated with ECT and the group that are treated with esketamine. So these are mainly the costs of TRD, are they? Or
yeah, so we had quite high costs for TRD because we included, we had this study that had looked at, you know, all the costs around the illness. So from a societal perspective, we have a lot of costs for TRD. And then we also have the cost of loss of productivity, so not working. And we had the cost of informal care as well.
So the difference in the cost of the ECT and the esketamine in both of these scenarios is actually probably dwarfed by the cost of the illness, isn't it? If you think of that, just the cost of delivering ECT and the cost of esketamine, that it looks to me as if that's going to be quite small by comparison to the societal costs. Yeah, and okay, that's great. So and then the QALYs that you've got. So they're, I mean, just not as somebody who doesn't work with QALYs, it seems to me that these numbers are actually quite similar, aren't they? The 14.85 and the 14.26.
Yeah, because we have a lifetime perspective, so it's not a huge difference in QALYs from a lifetime perspective, but we do have more QALYs for the ECT.
And so the assumptions that you make about relapse, can you tell us a bit about those?
So what do you mean by assumptions of relapse? Sorry.
Maybe I'm showing my ignorance and asking the wrong question here.
No, it's fine, just so I understand. You mean how it worked in the model, how patients relapsed, or?
Well, I suppose, yes, if you could say a bit about how it works in the model and also where the data came from.
Okay, so we had that. Maybe I should go back to. To this one.
Yes, yeah.
So we had all the patients then starting in this state depression.
Yeah.
And then after 1 month, if they were still depressed, they went to this state, and if they reached remission, they would go to this state.
Yeah.
And then after 1 month, the patients who are in remission, they can, if they relapse and they have had ECT or esketamine and it's been successful, they will go back to receive esketamine and ECT. So the patients who receive esketamine or ECT will continue to receive that when they relapse, as long as it has been successful. And then the patients who are relapsing on standard treatment, they will continue to receive standard treatment. And the relapse for esketamine we had from the sustain trial, and the relapses for ECT was from a randomized controlled trial in England, and then we had the TRD trial for the relapse rate for standard treatment.
Right, I think that there's some interesting things there about how one might, how one treats relapse, but perhaps others can come back to that in a bit. So I mustn't hog it. There's lots of questions here. In your study, you are using results from Transform 1, our fixed dose, instead of results from Transform 2, our flexible dose pivotal and registrational study. Is there a reason for that? I mean, I think that's an important question.
Yeah. Yeah, I agree. That is an important question, and we did discuss this, which study or which proportion of remission to use, and we decided to go with the more conservative one. We saw that study had slightly higher levels of TRD, and they had slightly higher MADRS scores We also looked at 2 other cost effectiveness studies who had pulled the results from the 2 or 3 of the transform studies, and they used a lower remission rate that we did. We also adjusted for this in the sensitivity analysis, where we increased the remission rate, and we didn't see that it made a difference. We still had the same conclusion to the results.
Okay, so that's an important thing, isn't it? And if you had just combined transform 1 and transform 2 in your sensitivity, it wouldn't have made any difference. Seems to be
no. So yeah, exactly. So there was another study that combined those 2, and their remission rate was slightly lower than the remission rate that we used. And in the sensitivity analysis, we increased the remission rate to 50%, I believe, and we still had the same conclusion.
Yeah, okay. And then Stefan from Berantane, who judging from the way this is couched, is from Janssen, also asks a question. Could you give us more details regarding the estimate of the ECT cost, session cost? The source is not giving any detail on the model used. So you talked a bit about how people would have been prescribed ECT, I think, in 2 appointments by a psychiatrist. So that's the cost that you're sort of attaching to the business of starting ECT. But then you've got, 2 ECT appointments over 4 weeks. I guess that you're thinking that the session, the course of ECT is 8 sessions long. But where do you get the cost for that? How do you estimate the cost of the ECT?
So yeah, it's like you're saying. So we had 2 costs that was just for psychiatrist appointment, and those 2 costs we took from NHS reference cost. And then we took the cost of ECT from NICE. They had estimated how much a session of ECT costs, and then we inflated it to 2019 value.
Okay. So you've gone with a nice model there. Can you tell us the 2 scenarios where esketamine was superior?
We didn't have any scenarios where esketamine was superior. We had 2 scenarios in the sensitivity analysis where ECT wasn't cost effective. Let me have a look at what they were. So in the maintenance model, when we doubled productivity loss, and when we increased remission rate the second time, then from a societal perspective, maintenance ECT was not cost effective compared to esketamine anymore. But we didn't have any scenario where esketamine was cost effective compared to ECT.
Okay. And just this reminds me of just thinking the thing that just as a clinician I'm thinking about when I'm hearing about your original model, if you like. The ways in which this is different from clinical reality is that if somebody has ECT and then relapses, then and benefits, then the number of times that they have ECT again may not be very great. But what you're trying to, I can see that what you're trying to do is you're trying to make a parallel comparison. In a sense, you're saying if you have to have esketamine every 2 weeks, as a long-term treatment, then it's right that relapse with ECT, you should say that you go back to ECT in order that you're going to be able to compare the costs in a way that's sort of fair for the 2. Have I understood that correctly, or have I got that wrong?
Yeah, no, I think that's a good way of summarizing it. I also think with the maintenance model, that wasn't something that we made initially. We had a comment from a reviewer that it wasn't maybe always a good comparison to compare to compare esketamine with ECT and then medication. So then we added the maintenance model where the individuals would have ECT throughout.
Yeah, okay. Ramesh says, excellent study. Was the anesthesia cost considered?
Yeah, so in the cost for ECT, that's the cost that NICE has. They have included all the costs for administering ECT. So the anesthesia, the nurse, and the overhead costs for being in the building and those kind of things.
Okay. An anonymous attendee says, if I understood correctly, the cost difference is very small in percentage terms, but makes a comment that racemic ketamine is practically free. So obviously this speaks to your previous uncertainty about the relative effectiveness of ketamine, of racemic and nasal esketamine. So I think you've answered that. Tiago says, in esketamine, was the human resources needed to administer esketamine included in the costs of esketamine, I think is what he's saying.
Yeah, it was. So the resources that we used for esketamine was, excuse me, was so the 2 psychiatrist appointments, one at the beginning and one at the end. And then every time the patient goes to the community mental health team, we had we included the cost of a nurse visit or a nurse visit. I've been reading other studies that looked at this, and they said sometimes it can be challenging to quantify this, because with esketamine, the patient is administering the medication, and then they are supposed to be observed by a nurse for, I think it's 2 hours afterwards. I've seen when they've done different cost effectiveness analysis, they've looked at, so if you have one nurse, can they observe 5 patients at the same time and those kind of things. But we included just the cost for a nurse visit. So we had one nurse visit or one nurse appointment every time the patient had a dose.
I see. So there's one nurse for each patient. Yeah. Okay.
But we had the cost as one visit, so we didn't take it as, because in the NHS reference cost, it's per appointment or it's not per hour. So we didn't include one nurse for 3 hours. We had one nurse visit. I
see. Okay. Yeah. Okay. Good. So I think you've addressed the question about what costs are included under the healthcare costs of ECT. Mike Harris asks, is the societal cost before treatment? And so yes, the societal cost that you're quoting for TRD is before treatment, because one would have expected the societal costs to reduce if the treatment is effective.
So the cost, if I understand the question correct, so the costs are, we are not including any costs sort of before the model or before the patients start treatment. So when the model starts, they're 45 years of age and they have treatment-resistant depression. That's when we start counting the costs.
Okay, yep, I think that answers the question. Anonymous says, if this study is used to influence health policy, I think it's extremely misleading. It should have also evaluated racemic ketamine. The conclusion would likely have been the opposite. It's also unclear whether ECT side effects have been taken into account at all. Yes, that's a good question. Is there a sort of way of accounting in health economics for side effects, other than presumably the cost incurred by treating those side effects?
Yeah. So first of all, we didn't look at evaluating racemic ketamine. We looked at the intranasal esketamine, and with the side effect, you can account for those side effects by adjusting the QALYs. And it's something that we did in the sensitivity analysis. So in the sensitivity analysis, we lowered QALYs when the patient received ECT, and then we increased the QALYs when the patient were in remission.
Okay. Yeah, that makes good sense. Yes, there's a question here about the standard, how the standard treatment compared. Was it more or less cost effective than ECT or esketamine?
We didn't look at comparing standard treatment. We only looked at comparing ECT and esketamine. So the standard treatment was something that the patients received when they did not respond to ECT or esketamine, and it was also something that they received when they were in remission.
Okay. And the next question is, what proportion of, what estimates are you using for relapse? And are you assuming all patients relapse at the same time point? So presumably that varies a bit between the ECT and the esketamine.
Yeah, so with the ECT, we had 2 studies.
Yeah.
We had one study that looked at relapse in patient who had responded to or remitted on ECT, and this was over 6 months. So we have 2 equations where we can recalculate the relapse over 6 months to calculate it into relapse over 1 month. So we do that for all the transition probabilities. So we have adjusted them all, so they are for 1 month.
Okay. Yeah, I think you've answered the next 2 questions. Tiago asks about the numbers needed to treat and the numbers needed to harm included in the analysis. I guess that's just about what your inputs are for the remission, isn't it? With ECT and with esketamine, and I think we've talked about that.
Yeah, we didn't include that in the study. We had the sort of transition probabilities, the effect or the risk of relapsing and remitting.
Yeah, okay. I have one final question, which is before we move over. You've done a lot of sensitivity analyses, and obviously the key sensitivity analysis would be one based on cost. So, at what cost would esketamine be dominant?
Well, when we did our analysis, in all the scenarios, we had ECT resulting in more QALYs than esketamine. So I don't think that we can have a cost where esketamine will dominate ECT, because we still have more health benefits from the ECT.
But okay, so let me ask the question a different way. At what cost would it be more cost effective?
We didn't look at any of those costs, because we saw that ECT generated more QALYs. So in this study, we didn't look at that, but that's something to look at in a future study.
Right. So if ECT always generates, I mean, but if for example, you halved the cost of esketamine in a negotiation with the government for your cost of your esketamine, could that then result in an ICER that was within the range of for esketamine that was within the range?
I think that because you would still have more QALYs, you would still have more health benefits from ECT. So then you would have to think, would you want to not give ECT and give then, if esketamine was cheaper, would you want to give a cheaper treatment then, but you have less health benefits? Because in this study, we also had the assumption that, or when we looked at the transition probabilities, we saw that ECT in most in studies had more patients in remission than in esketamine. So we had higher transition probabilities for ECT than for esketamine. However, if we were to do another study, we had other data and we would change those transition probabilities, then we could look at what cost esketamine at what cost esketamine could be cost effective. But in this study, we had more qualis for ECT, so we didn't look at that.
I can't resist asking one more question. I'm sorry, and we will move over. But I want to turn the recording off in a moment. I want one more recording on the record. One more question on the record, and that is, obviously, you've got a very clever spreadsheet that sort of with a lot of formulae that manage these sensitivity analyses depending on the inputs. Is it ever normal in health economics to make those spreadsheets publicly available so that people can put in their own costs and, you know, fiddle with the model?
I don't actually know that. And maybe Fredrik has the answer to that. I'm not sure, actually.
I think that we have a very poor excuse for not making them available, so to say. But in general, I don't think many are doing it. I have not really seen anyone doing it. But technically, it should be fully possible. And I would think that if anyone have the interest, that we might be able to help with that. But that is, Kinza knows her sheet better than me.
Right. Yeah. Okay. And I imagine it would be difficult for anybody to actually really get to grips with it because it would be very complicated. Anyway, what we're going to do now.